You can see.
All right.
Okay, ma'am.
Mm. Thank you. Thank you very much, team. A very good evening, everyone. I'm Dr. Rajashri from the medical team. And to begin today's show, I would like to give you an overview about Genova. So, at Genova, we believe in transforming healthcare through innovations, collaboration, and education. So, we aspire to transform the healthcare of millions of people, especially through the implementation of technological solutions. And in that process, we be the top 10 technology driven companies in the world. So, we can proudly say that in last one decade, we have made a difference in hundreds of thousands of human lives, and over another decade, we want to make it to another thousands in multiplication. So, who are we? If we go next, Ronak, yeah. So, Genova is a Pune based biotechnology company dedicated to transforming healthcare. Now, our mission is to bring cutting edge solutions to patients, providers, which can improve outcomes and accessibility. The milestones that we hold since 2 decades, we have brought to you a wide range of biotherapeutics from Vintor, Elextim, Emgrest, Tenectase, Gemcovic, Hemsil Junior for pediatric cancer catering to therapies as well. So currently we have a wide range of therapies as well. If you go next, yes. That's stroke, cancer, cardiac, renal, ophthalmology, tuberculosis, and also many infectious disease. Now today I am honored to welcome you all to this live workshop on where we will deep dive into difficult to treat cases or interesting cases on thrombosis, and exploring how real world clinical insights from you all can transform care outcomes. Without further ado, let me kindly introduce you to our course director, Dr. P. Vijaya Ma'am, President of Indian Stroke Association, a member and key opinion leader of Asian Stroke Advisory Panel. She is a past president of AP Neuroscientist Association, a certified stroke assessor for primary and advanced stroke centers, HOD Department of Neuroscience Lalitha Hospitals, Guntur, and director of Anki Nadu Stroke Center. That's India's first accredited advanced stroke center by QAI. Her honors, awards, and recognitions goes like she received Dr. Vijay. She received a lot of such recognitions, starting with gold medal winner award from WSO for public stroke campaigns, and diamond status awards from WSO Angels Initiative registry for best stroke care. She's been a faculty of DNV Neurology and received Best Teacher Award from ANBAI twice, received many awards including Times Health Excellency Award in 2023, Legend in Neurology and Stroke Advocacy. She pioneered in stroke care in Andhra Pradesh and interventional stroke therapies in India. She's been a principal and investigator for many landmark stroke trials with more than 60 publication and many book chapters. She has a lot of scientific papers, presentations, and international stroke conferences. And her latest original research paper, developed through international collaboration, has received prestigious grants like Paul Dubé White International Scholar Award as well. A warm welcome to you, ma'am, on behalf of Genova.
Thank you. Thank you. Mm.
Next, we have Dr. Veteran Major General Dr. S. Kumara Velusa. He is currently associated with Esther Ramesh Hospital, Guntur, Andhra Pradesh, as an HOD in neurology, specialty in neurology, stroke medicine, movement disorders, and neuroinfectious. Over 32 years of experience in Indian Army across country, and superannuated in 2013 after 36 years of service in the Indian Army, with a reflection of a long distinguished career. He has over 40 publications in Stroke, Journal of American Heart Association, Lancet, Journal of Neurosciences, Annals of Indian Academy of Medical Sciences, New England Journals of Medicine. He is recognized for exemplary professional acumen and dedication to patient care, especially highlighted by one such event, a notable case where he saved the life of a young soldier with cerebral venous thrombosis at high altitude in a remote medical facility. So, a warm welcome to you, sir, on behalf of Genova family.
Thank you very much.
Next, we have Dr. Usha Kiran Behera, ma'am. She's a consultant neurologist, currently associated with Lalita Super Speciality Hospital, Guntur. With an over 4 years of excellent experience in this specialty, she has been a faculty and thesis co-guide in DNB Neurology teaching program. She's involved in a sub-investigator in many ongoing clinical trials, presented cases on GBS case series in Ep Neurocon 2024, febrile encephalopathy in AP Neurocon 2024, lipoid proteinosis in TNSCon 2019, clinical profile and prognosis factors in GBS again in TNSCon 2020, recurrent stroke in young in INCon 2019, Kennedy disease in AP Epicon again in 2015. Her publications goes like clinical spectrum research factors and management outcomes in cerebral venous thrombosis, a retrospective analysis of 100 consecutive case of stroke in young patients with 3 months of follow-up in a single advanced stroke center in India. Statin induced rhabdomyolysis, a rare case, and a clinical scenario of hypothyroid induced rhabdomyolysis. A warm welcome to you, ma'am, on behalf of Genova family. Next, we have Dr. Reshma Meru, ma'am. She's a consultant neurologist and currently associated with Lalita Super Speciality Hospital, Guntur, previously associated with Katuri Medical College and Hospital, Ramesh Multi Speciality Hospital in Guntur, and Nilima Hospitals in Hyderabad. Her papers presented goes like clinical and radiological profile of uh, tuberculosis meningitis in the tertiary care center, a retrospective study which has been presented in World Congress of Neurology in Dubai in 2019. Next, clinical spectrum of meningitis and encephalitis at a tertiary care center, a retrospective analysis at AP Neurocon in Vishakhapatnam in 2019. Hirayama disease, a case series study from a tertiary care center in Iancon, Raipur, September 2018. Clinical and etiological profile of granulomatous ring enhancing CNS lesions in a tertiary care center, Epineurocon, in June 2018. She's been a life member of International Parkinson and Movement Disorder Society, Movement Disorder Society of India, Indian Association of Pneumology, Indian Stroke Association, Indian Society of Sleep Research, and Indian Medical Association. So, with this, I would request our course director, Dr. P. Vijaya ma'am, to take over, and a warm welcome again to our guest speakers and panelists. Over to you, ma'am.
Thank you, Rajeshri, for this elaborate introduction of all of us. Thank you so much. And I think let's start the academic part. It's the stroke is always the most intriguing and most challenging acute case that we all face day to day. And today we have two very interesting cases where at every step we had a lot of issues to discuss to decide about the management. First, I would like to call upon Dr. Reshma to present her case. Over to Reshma.
Thank you.
Mm.
Thank you, madam. Good evening, sir.
Kumar Veer, sir. Yeah. Yes, Sama. Please start.
Good evening. Good evening, Reshma. Please go ahead.
Uh, And I thank my moderator, Professor Kumar Velu sir, extremely profusely for his contribution and for his involvement in this. We'll have a lot of good discussion, I'm sure.
Yeah. Hopefully.
Good evening, everybody, and going on with stroke and seizures. So, a 56-year-old male who is a known hypertensive and post-PTCA on epilepsy, he came with complaints of slurring of speech and weakness of right upper and lower limb since 2 hours. So, his he tried lower limb weakness, though not associated with any LOC, ENT bleeds or injury. There was difficulty in speaking.
Ma'am, we can't hear you.
Reshma, there seemed to be some problem with the connection.
Looks like slides are clear.
Mm. Hello, Reshma. Mm.
I think she's lost connection, ma'am.
Oh,
5 days he was asymptomatic, and on the 25th he presented with this episode with weakness in 2 hours window period.
Dr.
So his
Reshma,
past history and
sorry, ma'am.
yes,
Ma'am,
mm.
we lost your connection in the middle. Could you please reshare the slides and also take us through the case once again?
So briefly,
Go
you
through
please
both the-
go through the slides
Yeah.
again.
okay, okay,
Keep it in a fixed position so that the connection will not be problem.
okay.
Slide, please share your slide.
Uh, is it coming?
No, we can see you, not your slide.
1 minute.
Unshare your presentation and share it again. It might come again.
Uh, okay.
Ma'am, if there is some network lag, you can just switch off your camera so that it won't take too much of your
Yes.
bandwidth. Yeah.
Okay.
You switch off your video, Reshma, and so that
Yes, ma'am.
yeah, please, thank you. Yeah, now just briefly again tell us the history and then we'll go on.
Is it coming now?
Yeah, it's coming.
56-year-old male, known hypertensive and post-PTCA patient. On deplant, he came with complaints of slurring of speech and weakness of right upper and lower limb since 2 hours. So he had episode of this right upper and lower limb weakness with the fall, which was not associated with any LOC, bleed or injuries, and difficulty in speaking. He came within a window period of 2 hours, and there was an NHS of 7 at the presentation at ER. Prior to this, he had a similar episode 4 days prior to this, where he had giddiness, and during his routine walk, morning walks, he was not able to initiate his walk, and with some clumsiness of the hand and increased yawning. The total episode lasted for about 15 minutes. As he was a regular patient to the cardiologist, he visited the cardiologist. However, he forgot to mention about this episode, took his regular medication, and went back home. Uh, Till 25th, he was normal when he presented to the ER with these symptoms with 2 hours duration. His past history was significant for PTCA to the RCA and LCX in 2023 and 2024 respectively, and he's a known hypertensive on telmisartan. So, and there's history of prostatomegaly. He takes mixed diet and has normal bowel and bladder movements, a non-alcoholic and non-smoker. On presentation to the ER, he was as he was in a window period, he was taken up for a CT scan, which showed doubtful an infarct with a doubtful hemorrhagic transformation at the level of the centrum semiovale, the left MCA territory. So, following the CT scan, he immediately improved, and his symptoms from an NIHS score of 7 to 0, and his vitals were within normal limits. So So thrombolysis at this point of time was deferred in view of hemorrhagic infarct and also rapidly improving symptoms. And he was taken up for an MRI, brain with angiography. So this was his MRI, which showed an acute infarct in the left CG region, which was
In
also
the flare also.
positive
In
in
the
the
flare. It's the
flare,
yeah.
which was also positive in the flare. And this is the MR angiography showing stenosis, mild stenosis at M2, M3 with ICAD changes. So considering it as a low NIHS and a small infarct, which was also flare positive, so he was loaded with antiplatelets and tirofiban infusion was planned to start. So he was started on zero point 0.5 micrograms per kg of tirofiban over 20 minutes, followed by zero point 0.1 micrograms per kg. And total dose of 15 mg was given over 36 hours. During this course of treatment, CT imagings were repeated, which did not show any evidence of an bleed. And following this completion of the tirofiban infusion, he was started on ticagrelor. So at 48 hours, his NIHS was 1 with the right upper limb ataxia. So his subsequent Doppler, which showed mild stenosis of the right ICA, and he was stable. Then, following third day of hospitalization, he had an episode of right facial twitching with right leg involuntary movements, and they lasted for about 1 minute. It was followed by slurring of speech and right upper and lower limb weakness, which lasted for 30 minutes. And this weakness improved without any deficit. So at this point of time, his sugars were normal, and CT brain was repeated, which did not show any increase in the infarct or any new bleed or no new infarcts. So this was considered as a focal seizure and an AED was started. And subsequent EEG was done, which was normal. This is the repeat CT done at this point of time, which showed an infarct in the same corresponding area, which we saw in the initial MRI, the left CG and posterior caudate posterior region. So, following this episode, the same day evening, he had a similar episode of a yawning, followed by typical stereotypical movement of right upper and lower limb with weakness and posturing, facial deviation, and slurring of speech. During this entire episode, he had the speech arrest and he was intact and aware. And the episodes they lasted typically for 10 to 15 minutes, and he recovered completely to normalcy. So again, another second AED was added at this point of time. The subsequent day was uneventful. However, the fourth day, he developed another episode, two episodes actually. First episode at around 7 p.m. and then again 7:30 p.m. Each stereotypical with right upper and lower limb weakness and slurring of speech. And this was preceded by yawning episodes always. And at this point of time, the initial AED dose was hiked, a second AED was added, and again a CT scan was repeated. So it would show the similar changes to the first scan, first and second scans. Uh, the next 2 days, he did not have any episodes. However, there was slight 4 by 5 power of the right upper and lower limb, but no dysarthria or aphasia. And then for 3 days after this, he had another episode. This was the sixth episode where there is always yawning and then a stereotypical movement of the right upper and lower limb with weakness and dysarthria. All these episodes, they used to typically last for 5 or maximum of 10 to 15 minutes. But this episode, there was weakness which lasted for about 2 hours. And this was considered as a Todd's palsy. And during this course, we had done EEGs which seemed normal. So at this point of time, a third AED was added. And dilemma of whether this was a focal seizure or capsular warming syndrome was considered. And the AED doses were hiked up. So repeat scan was done, which again showed the same changes. And CT angiogram was done of brain and neck, which showed supraclinoid and cavernous ICA narrowings of 20 to 30% and M2, M3 stenosis. And the neck angiogram was normal, which did not show any stenosis of the ICA or the common carotid on the left or right side. So on 2 days later, he had another episode on fourth, and then again the eighth episode, which occurred 2 days later. And this episode, complete weakness. This weakness did not recover, and he developed complete weakness with a 0/5 power of the right upper limb and facial deviation with dysarthria. At this point of time, an MR imaging was repeated, and this MR imaging showed an increase in the size of the infarct in the which was present in the left CG region previously, and the same infarct increased in size. And the MR angio did not show any new changes or a large vessel occlusion, but changes of same ICAD such as M2 stenosis and was there. So at this point of time, along with the anti-epileptics and antiplatelets, anticoagulation was also started with heparin, which was subsequently changed to Clexane. And as he was already on ecosprin and ticagrelor, an antiplatelet was changed to the second antiplatelet was changed to cilostazol. So and statin was changed from atorva to rosuva. So at this point of time, from over the next few days or 5 days, he improved. And the workup for stroke did not reveal any sources of cardioembolism. Holter was normal and echo was normal, which was done prior as well as repeated again, which is normal. So at this point of time, whether this is an ICAD or a capsular warning syndrome or a branched atheromatous disease was the diagnostic dilemma. So over the next few days, his power improved with rehabilitation. And before planning for discharge, the anticoagulation was stopped for 48 hours as there were no further episodes. So he was discharged on ecosprin, cilostazol, and rosuvastatin. Um, his NIHS at discharge was 8 and an MRS of 2 with the 4/5 power of the right upper and lower limb with mild facial deviation and dysarthria. He subsequently came for 2 follow-ups and he improved. And repeat imaging was done, which showed the same changes, and even a CT angiogram was repeated, which also did not reveal any further occlusions. These were the follow-up imaging. And this is the patient who improved with the medication at almost 1 month. This is the MRS at 1 month. He was able to. Is the video playing?
Yes,
Yes, it
ma'am.
is playing. It is playing. Yeah.
So, so to conclude, we as the response was there with antiplatelets, so and he stabilized on cilostazole, we considered this as a capsular warning syndrome due to occlusion of the lenticular striate arteries or an M2 atheroma. His, as he presented typically with the pure motor hemiparesis and stereotyped TIAs, which so but to end this case, we were interested in discussing few points whether we should consider IV thrombolysis in rapidly improving symptoms or not, and what is the best strategy in a capsular warning syndrome, and what would be the best combination of antiplatelet drugs.
Thank you. Is that all, Reshma? You completed your
Yes,
presentation? Yeah.
yes,
Thank
ma'am.
you. Thank you, Dr. Reshma. And it's really a very challenging and very interesting case. Sir, I would like you to open the discussion with the
Yes, ma'am.
first point. What do we do with a rapidly improving symptoms in a case within window period? What will
Yeah.
be the decisions at this
Yeah.
one? Right.
Capsular warning syndrome is always a high risk factor for getting a full-fledged stroke, which happened in our patient. So in patient with rapidly improving system, do we do IVT or not? Generally, no. But in a patient with capsular warning syndrome, even the patient reports within the window period, which is appropriate for thrombolysis, irrespective of flare positivity or negativity, I think we should go ahead and thrombolyze the patient just to prevent a subsequent catastrophic stroke. That's the only purpose that giving for IVT in such a setting, and capsular warning syndrome is known to land up with a major stroke within 72 hours by the literature, to the tune of about 48% of patients with capsular warning syndrome lands up with a major infarct if you don't tackle them in time. Now, having said that, it's tirofiban is mentioned, and Dr. Vijaya is an expert on tirofiban. So she has done original research work on tirofiban. So giving tirofiban is always an additional benefit in such settings. Now, coming to best strategy in capsular warning syndrome, the first thing is to make an appropriate diagnosis. Once you made a diagnosis of capsular warning syndrome, you have to be careful that the patient does not have any cortical features in the symptomatology. That's the most important thing for making a diagnosis of capsular warning syndrome. If a patient has got a cortical symptomatology in the form of any language dysfunction or to some extent seizures and other cortical phenomena, then you must revise your diagnosis or you have to look for an additional lesion in the cerebral cortex. That's the second point. But this, coming to best strategy, the strategy, as it looks like, it is dual antiplatelets with statin and correction of risk factors, especially in our setting. Hyperglycemia is a major risk factor in our setting, which needs to be looked at. One point of interest, which I thought, apart from hypertension, type 2 diabetes mellitus, obesity, hyperlipidemia, and correction of behavioral dysfunction in the form of smoking and excessive alcohol consumption. My only point of concern, which I may ask, is does the patient have a history of snoring? Just because that's a obstructive sleep apnea is coming in a big way as a risk factor for stroke, that we should try and look at. As far as the strategy for stroke, yes, when the patients do not respond adequately with dual antiplatelets exhibited in appropriate doses, there is a role for anticoagulation, short-term approach. The role of silastosone is not evidenced in literature, but yes, it can be given because it is also an antiplatelet agent in that sense. Coming to the last point in discussion, what's the best combination of antiplatelets? Ticagrelor was given. That's a very effective drug. That's fine. That should have been, it's fine. But otherwise, the standard combination of aspirin with clopidogrel in Indian patients, especially in males, should be a reasonably good combination. But our giving combination with ticagrelor is fine in place of clopidogrel. Having said this, the best combination of antiplatelets is yet to be decided, and the duration of dual antiplatelets is yet to be confirmed.
Yes, sir.
The duration of antiplatelets, as per chance 2 trial, we can extend it up to 30, 90 days. But in Indian settings, it may be worthwhile to continue beyond 90 days also dual antiplatelets. Now, did the patient have hyperlipidemia, if I may ask?
Uh,
Yes, sir.
His lipids were normal. He was on actually, sir. So let me also, so the same points I will also go through with my point of view.
Yes, ma'am.
Lipids are, do you have any report? Just check Reshma meanwhile.
There is no dyslipidemia, sir. They were within normal limits.
Women's comments. Okay. Now you should take me to the slide of the questions again. So, sir, so what happened was this particular patient, we were not suspecting capsular warning syndrome in the first go. Since he was a cardiac patient on post PTCA, the first impression was we may be cardioembolic stroke at in the ER. And then what happened? The resident was there, and we were all busy in, I think, Neuro Club. Sometime we were not available immediately. So he looked at the scan, which had a speck of small hematoma, and the infarct was in the coronary area. It's not in the typical capsular area, the CT scan initial. So the thought process went like this. It was patient was on DAPT. It may be a cardioembolic stroke, and patient improved to 0. NIH was 0. So at that point of view, we thought there may be risk benefit ratio may be a little bit more on the risk side. And then we sent him to MR, and then MR also showed, then it showed the definite infarct without much hemorrhage. And patient was normal. Patient had a 0 NIH or maybe minimal ataxia, but in the records it was normal. He was under observation. He started on DAPT and MRI. I think the CT scan was shown, I mean, CT angio was shown in a large view, but it had what looked like a plaque in the nearer the onset, the denticulocyte branches. near the lenticulostriate branch origin, there was an irregularity of the vessel. So, which we thought maybe a atheroma sitting there, and it may be obstructing the lenticulostriate branches. We started on tirofiban at that stage. Because he was already on DAPT, he had the stroke and he had a vessel wall pathology, which may be related to the platelets. That was our thought. And then after that, he quite stabilized. In fact, he improved to normal, and that minimal thing also was not there. After shifting to the ward, he started having these fluctuations. By definition, capsular warning syndrome usually 24 hours or maximum 72 hours. But this patient had fluctuations starting after 72 hours. That was an interesting point in this case. And once we started one episode, we thought it is yawning and typical stereotypic things. They must be seizure phenomena. We treated with anti-epileptics, and then he went into the another episode of dense hemiplegia. That is when we thought we should change the combination from ticagrelor and aspirin to a anticoagulant. And then on anticoagulant again, he was having again fluctuation, one more fluctuation. And then that is the where we change it to the, actually it is as we were saying, the silastazole is not evidence based. We never use it as a first line of drug for that matter in the acute stroke. But we did not have any other choice but to try this one. It so happened, incidentally, this patient responded well to this combination, silastazole and aspirin and a high dose of rosuvastatin. And after that, he did not have further episodes till now. So we are now hesitant to change, get him off that combination because he was having a good response clinically. Meanwhile, we ruled out all causes of cardioembolic stroke reasonably. This is the history and this one. And this interesting case because it was the fluctuations happened after 72 hours and he responded. He did not respond to ticagrelor. He responded to a lesser antiplatelet, namely the silastazole. And the patient had improved to normalcy despite there is a large infarct there. Moderate infarct. It is, I cannot say it is a typical capsular infarct, but it is a moderate infarct. These are the three interesting points in this case. So, any other
And
questions and
any
discussions?
role for arterial wall imaging? It
Yes,
just
sir.
crossed my
Sir.
mind.
Exactly. No, no. We were keeping that. That was what we are waiting for. Three Tesla MR with arterial wall imaging is what we are planning next in him.
Okay.
So that is the case, sir. So shall we move on to the next case, or you want
Yes,
to
ma'am.
have any other comments or questions on this?
Nothing. Nothing. Otherwise,
And
it's
of
all
course,
well
sir, that
covered. And
rapidly improving symptoms, the Aramis we have very clearly the minor stroke. He had the NIH was not very bad even at the start. It was only 7, and in an old man on DAPT. Aramis trial says don't give IV thrombolysis, and even our Tempo 2 trial with tenectase with the LVO also they were saying don't give if it is definitely a minor stroke. The decision is, as you said, whether it's really minor or it is a disabling stroke is where the clinical judgment comes, and sometimes it is difficult once in a while to decide about it. In a old
madam,
man, okay, sir.
madam, what I was saying is that if we are suspecting and if the patient has come within the window and if he can satisfies all the criteria for
Right, right. We should
thrombolysis,
never deny
where
the patient.
positivity is
Right.
not a contraindication for thrombolysis.
Correct,
That's
correct. Even there is a large infarct, nowadays, as you said, there is no contraindication. Even
no
that
con.
one third, 50%, and that's all gone. We have to look for to give IV thrombolysis rather than withholding it. Point well taken, and that's why
Our
that's one of these
inhibitions to
points.
give thrombolysis should go down further.
Right, correct, sir. Very, 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 very well said that. So, should we move on to the second case?
Yes, ma'am. Yes,
Is
ma'am.
there audience questions in this? No, we don't have those things.
Eh,
No questions, ma'am.
Not yet.
No
No.
questions. Okay, okay. Then we'll move on to that second case. Sir, shall I invite Dr. Usha? Are you ready,
Yes,
Amma,
ma'am.
to
Yes, ma'am.
share your, with your
Yes.
permission? Okay.
Yes,
Please
ma'am.
share your screen and
Yes, ma'am. I'm trying to share my
yeah.
screen. Good evening, ma'am. Are my slides visible, ma'am?
Yes, yes, they are visible.
So, a very good evening to one and all, respected ma'am and sir. Thank you for giving me this opportunity. So here I'm going to present an interesting case of stroke in young.
Kindly show it your slideshow mode, Usha.
I have started slideshow
Make
mode,
it
sir.
slideshow.
Okay.
Mm.
I am in slideshow mode actually, but
But here your is a smaller one.
let me do it once again.
Maggot.
Is it coming, ma'am? No.
No, not yet.
For me, it is showing the complete slide actually.
Unshare and share again then.
Stop sharing.
Ma'am, I have your presentation. If you are okay, I can present. I think you have
Okay,
shared already.
let me just try to share it again. And
Yeah.
no, entire screen, I think.
The same. It is the same. It's not showing
It's
the full.
not in.
Yeah. Can we ask them to share?
Fine. Yes, ma'am. We can, but.
Krishna, can you share?
Yes, sir. Yes, sir. Can I share, ma'am?
Actually, let me.
Usha, try
I think you
once.
have to stop sharing.
Yeah, you stop. You
Oh,
stop.
okay, ma'am. Okay.
Yeah. Yeah. Right. No, go ahead. Go ahead.
Is it coming in full
Yes,
screen?
it's coming. It's coming.
Yeah.
Okay. Okay, then I'll go ahead. Yes. So here we have a 44-year-old male who is a hypertensive, but is
Change
not
the
taking.
slides. Change the slides. Slide change is not happening.
This is the first slide, ma'am.
Yeah.
Yeah. Yes. Right.
I think it's a little slow. Uh, so, a 44-year-old male who is hypertensive and has a very poor drug compliance. He was recently diagnosed to be hypertensive, and he's still contemplating that whether he has hypertension or not. He's a bus driver by profession, and he presented with sudden onset of swallowing difficulty, gait difficulty, was swaying while walking, and numbness of right upper limb and lower limb since 3 days. He was treated. He went to another hospital. He was treated elsewhere and presented to our ER after 48 hours. So window period was beyond 48 hours, and his vitals were stable. BP was around 150/90. He was conscious, coherent. There was obviously dysphagia. He was on a Riles tube. There were no limb weakness, but he had a very severe upper limb, lower limb, right upper limb sensory deficit, and very severe ataxia. And he came with these MRI images. There is a small infarct in the left lateral medulla. And so these were the reports which showed an acute infarct in the left medulla, and there was some chronic lacunar infarcts in the capsuloganglionic region and the bilateral corona radiator region. And the MR angio says there was mild etheromatous narrowing of the cavernous and clinoid segments, so bilateral ICS, and there was irregular stenosis of the left vertebral artery. So with the background of hypertension and a medullary infarct, we thought we were dealing with a diagnosis of acute ischemic stroke with a lateral medullary syndrome, with a ICAD and in the background of hypertension. But however, after some time, patient started complaining of neck pain. I think he had that neck pain, but he was more worried about the other symptoms. He just put it on a lighter note. But then he persistently complained of neck pain. And on further probing the history, he revealed that while driving the bus, he went for a resting position. And at that time, the bus had to put a very sudden brake. So he had a
The slides are still stuck. It's not moving.
sir.
Yeah, right now only we got the MR scenes.
Okay.
Madam, please let me know when to change. Just say me that change the slide. I will change, madam.
Next. You say next.
Oh, yes, ma'am. Next you say I will change.
Next. So this is we are seeing the MR with the lateral
Yes, ma'am.
medullary.
Yes, ma'am.
So
Because she described MR
you can
sometime back.
change. You can change.
Next.
Okay. So on further probing the history, he revealed there was a sudden deceleration injury. The bus had to put a very sudden brake, and he had sustained kind of a whiplash
Change.
injury. And he noticed the symptoms 2 to 3 hours after the event when he got down to have a cup of tea. Immediately after the event, he was asymptomatic. He noticed it 2 to 3 hours after the event. So are we there at that slide, sir?
Can you ask them to change the slide?
Yes.
So diagnosis, it has come. Yes.
Okay.
You are not able to
Can
see
you
the
change
screen?
the slide, please? Actually, I'm seeing my presentation.
No, you should see the what is projected. No.
So can we change the slide, please?
Yeah, okay. So we can change the slide now. Next slide, please. So with the complaint of his neck pain, and we didn't have a proper vessel imaging with them. There was only report was available. So we went ahead with the CT angiogram. The CT angiogram showed this very long segment narrowing with a very irregularities over the entire left vertebral and some part of the right vertebral artery. So, and we can change the slide, please. So the report was like these are the key points on the report. There was a long segment abrupt irregular luminal narrowing in the left V2, and there was a long segment irregular luminal narrowing in the V3 also. There was a hypodense intimal flap, and there was multifocal irregular luminal narrowing similar on the right vertebral as well. So the report conclusion is multifocal spheno-occlusive bilateral vertebral artery dissections. This was the report. Please change the slide. If the video plays. Okay, so we can see here the vertebral arteries appearing.
Use a
The left
pointer.
vertebral artery being very narrow as compared to the right vertebral artery. That is what we are seeing in the second part of the vertebral artery. And here, when the third part comes, there is a very gross narrowing of the left vertebral artery. So I have clear images in the next slides. We can change the slide, please. I wish I could share the slide so that I
Yes,
would
I have
point
changed,
out
ma'am.
the lesion, but next slide. Yeah. So here we can see the left vertebral arteries, the lumen is very narrowed. Next slide. So here, I wish I could point out at the lesion, but on the left side, the right side, we can see a small white dot, which is the right vertebral artery filling. But on the left side, there are two dots. That is, there is a double lumen in the left vertebral artery, along with a small hypodense flap in between the two lumen. Between the two white dots, there is a one gray zone, that is the hypodense intimal flap. Next slide, please. Yeah, the left vertebral artery is still narrow in course. Next slide. So here in this slide, we can see the left vertebral artery while it is looping around the vertebra, around the second vertebra. Here we can see a very diffuse long segment narrowing and irregularity. Similar changes we can see on the right side as well. Even on the right side, there are two lumen, the one above, and there is a small flap in between, and there is one more lumen on the right side. I hope people are able to appreciate it. If I had a pointer, I could point it out.
It's okay. You carry. Continue. Continue.
So next slide. So in view of his vertebral dissection, we had planned because we did a CT angio now, and he was 3 days into the course, and the NIHS was a little low. He was stable, so we planned for a DSA after stabilization after a few days, and we started him on aspirin, statins, and anticoagulants. We gave heparin initially, followed by tablet apixaban. We immobilized his neck, and patient was symptomatically improving. His giddiness, ataxia were a little better, and so he was shifted to ward. Next slide, please. So he was shifted to ward, and we were planning to go for a DSA. But on day 7, the patient suddenly developed a posterior epistaxis. There was a bleeding from nose, and on examination, there was a posterior epistaxis, and his BP shot up to 200 by 100 mm of HG. We were also giving a small dose of antihypertensives early. He was tolerating telmisartan 20 mg, but now he had a very high blood pressure of 200 by 100. So in view of that, antithrombotics, all the antithrombotics were withheld with nasal packing and all. And we gave injection tranexamic acid and all. So, and he was intubated just to prevent aspiration. His sensorium was normal though, but because it was a posterior epistaxis, we didn't want him to aspirate the blood. So he was briefly intubated, and the BP was controlled with the injection labetalol. Next slide, please. So he bled so much so that his hemoglobin dropped to 9.5. Initially, it was 11 to 12. And the coagulation parameters were normal. The PT INR was normal. So it was mostly because of the accelerated hypertension and not because of the anticoagulants, probably. So next slide, please. So we corrected the bleeding. We transfused him with fresh frozen plasmas and RBC transfusion. And very briefly, after the second day, he was extubated after we secured the hemostasis. And gradually, after 5 days, we reintroduced him with aspirin. And he was followed up after 10 days of discharge. He was fine. He actually, in fact, we followed him up to 1 month after the discharge. He was fine. He was with a very residual sensory symptoms. He so much so that he sustained burns from hot water bath over the right hand, and the ataxia and dysphagia were resolved. So this was his follow-up. He was fine. But at the end of the story, next slide, please. There are certain things to ponder upon. The first thing is whether we would have thrombolized him or not if he was presented in the window. So at the outset, we were not suspecting a dissection because he was not giving much of a history of pain. And even in the presence of a dissection, the guidelines say for extracranial dissections, we can go ahead with a thrombolysis. In case of an intracranial dissection, we have to rule out any subarachnoid hemorrhage before doing that. And it is hard, it is very difficult to contemplate the dissections in the intracranial dissections in the acute phase. The previous slide only, please. So the second question was any endovascular intervention could have been done. Endovascular interventions can be done. They are recommended in the intracranial dissections. Even in the extracranial dissections, the major motto is to prevent further progression of stroke, the further progression of stenosis and ischemic stroke. Here, in case because he was stabilized, there was no further progression of his symptoms, we thought of a diagnostic DSA later. We did not plan any endovascular intervention at that time. And the third question is whether to use anticoagulants versus antiplatelets. The literature is mixed. They say there is no difference among the in the European Stroke Organization trials and all. There is no difference among the two groups, but we can prefer anticoagulants over antiplatelets in the initial phase. And whether here in this case, as there was bilateral vertebral dissections, such an extensive dissection, whether to rule out any underlying arteriopathy. Here in this case, he was a hypertensive, which is also a risk factor for vascular dissections. So, and this was a first of a kind, and he was being a bus driver by profession, and there was a significant trauma history, very significant trauma history, and he might have had similar trauma in the past also. So at that point of time, we were not contemplating any underlying arteriopathy. However, clinically, there were no morphinoid body habitus, no the lenses, everything were normal. There were no markers of any obvious arteriopathy in this case. But however, I would like the stalwarts in this field to discuss over these points. Next slide, please. So the take-home message was the presence of extracranial arterial dissection is not a contraindication for thrombolysis. In our case, however, the patient presented late, so we did not thrombolyze. And this case, initially, we were thinking of it as a plain ischemic stroke secondary to hypertension and ICAD. However, there was another existing etiology in this case, which we got to know from the further history. So a keen history taking is always the key. So that is all from my side, sir. Thank you so much.
Yeah. Good case, Usha. Well presented. The point that may be of relevance is in such a setting is that, first of all, we need to have a little bit better imaging to diagnose dissection, to call it dissection. And arterial dissection in the extracranial portion is fine. There was a history of trauma, isn't it?
Yes, sir, there was a history.
History of trauma.
He did not recognize it at initially, but when we probed,
but we had taken it retrospectively that
yes,
he didn't give a history of trauma.
yes.
So it should be considered as traumatic. In fact, it is known as chiropractor's this thing. That's the reason chiropractic, especially of the neck manipulation, went into disrepute following these such events. So one should never undergo. And he had any other risk factors in the history apart
He had
from
hypertension,
this
sir.
neck
He was a
injury?
non-hypertensive.
Hypertension, which was properly uncontrolled.
Uncontrolled.
Did he have any hyperlipidemia associated with it?
No, sir. There was no hyperlipidemia.
Because that's one thing that we should keep in mind. And
Yes.
as when the patient has got, in all probabilities, he might have had a dissection, but we need to have maybe that we could have pushed in for a DSA a bit earlier. That's one possibility. If you
Yes.
had pushed in for a DSA, we could have picked up the lesion, and then with certainty we could have gone further for any intervention as appropriate.
Actually, we were planning for the DSA, sir, but meanwhile he had this bleeding episode and all. And
Yeah.
later we were planning to do a DSA, but we unfortunately lost him to follow up because he was so well and he started his going to back to his profession. Initially, we advised him to go for a desk job and all, but he did not turn up for a DSA
Yeah.
actually. We are
Yeah,
trying to
that's
contact
important
him
is
and
when you have got a multiple dissection, be it traumatic or otherwise, we should not ignore it because it can portend a major posterior circulation stroke if not attended to or if not restricted. Medical treatment is fine. Whatever you have done is fine, either antiplatelets or anticoagulants. The WSO guideline, the AHASA guideline is a bit against giving the combination because it's a class 3 recommendation when you want to combine antiplatelets with anticoagulants. But having said that, there are quite a few instances where in clinical practice we need to resort to a combination of both. That's one point that we should keep in mind.
he also had some atherosclerotic disease and hypertension and some chronic lacunar infarcts also, sir. They were
Yeah.
also present.
So there was a this hypertensive disease along maybe that you see the most common cause of vertebral artery dissection in such an age should be considered as atherosclerotic. Maybe that the vessel is at an angulation whereby it does produce a possibility of getting that tangential compression on the vessel when the vessel is taking a curve across, especially when the neck is either hyperflexed or hyperextended. It can produce damage to the vessel acid, especially when it is getting out of the vertebral canal. That is where the maximum time the dissection starts. And also,
And being the
fortunately, the
profession of
posterior.
driver also, you would have had
Yes,
recurrent minor traumas in addition to the
yes,
present one. Mm.
yes. Jerking and other things, it does keep happening to the drivers when they keep driving. That's one thing. And the thing is, posterior circulation is that way privileged compared to the anterior circulation because they have got dual feeders into the posterior circulation. Until unless the vestibules are compromised, we rarely land up with the posterior circulation dysfunction. So that's one thing because we should be a bit trying to get the right vertebral also as dissection is not very conclusive at the moment that the imaging that we have got at the moment.
The flap was
So
visible in
that
the
we
left
need to,
vertebral. It was not visible on the right vertebral.
yeah, that we need to clarify further. Otherwise, I always say that all that ends well is fine. As long as the patient gets well is fine. So that we'll carry on with this thing. And that comes to this thing. This patient has got, as you have correctly said, extracranial dissection doesn't mean that you will not treat it. You need to treat that also and treat it appropriately depending on the clinical scenario. The definitive clinical treatment, in fact, they have seen that even with medical management, after a follow-up CT, angio, and other things, the dissection seems to have sealed off itself. That has also been seen. So if the patient is comfortable and a regular follow-up, maybe that it may be worthwhile calling those guys on phone and try and ask them come back for a review so that we'll try and look at it before we
Yes.
prevent a catastrophic posterior circulation stroke. That's all, ma'am. Madam, you
Yeah,
have
right,
some
sir. There are two.
comments?
Yes, sir. There are 2 points well taken. So one is in any patient, in young patients especially, uh, for that matter, acute stroke evaluation requires parenchymal assessment and vessel assessment, if possible, immediately. A good CT angio should always be a part of our acute stroke assessment. Unless the patient has come in the end of the window period or something, that another 5 minutes or this should not matter. We should always insist CT angio at least. Yeah, that is one point taken because all these vasculopathies need extra management in addition to the routine management. The second thing is history. As Rusha already highlighted, the good history will always be pointing towards an specific etiology, as is in this case. Third thing is IV thrombolysis can still be given even if we have a some suspicion of dissection, it is not contraindicated according to the guidelines. That is also very
Yes.
clear. Dissection is not a contraindication. However, the follow-up is equally important now that patient, unless probably his flap is already repaired and all, and unilateral it must be. However, the some of the patients may require at least 6 weeks anticoagulation till that acute period is the recurrent stroke may be prevented. This may be a good strategy. In this particular patient, we could not give long anticoagulation because he had a bleed already within the hospital. This
Yes.
was a concern. Luckily, he did not have another episode, but there was a high risk of recurrent stroke in this patient. That is was another point. This
Yes.
okay, sir. And any other thing? The post
There was one
circulation.
question in the chat box where somebody has asked the dual antiplatelets in males and men and women. See, the incidence of clopidogrel resistance documented is supposed to be higher in the Asian population, especially among women. If you are really going to look for, take that into cognizance, ideally one should get a clopidogrel resistance test in all such patients. Best thing in our country where affordability can be an issue, aspirin clopidogrel is the best combination for any patient, be it male or female. And if it affordability is not an issue, get a clopidogrel resistance test done. If the resistance test does not show any clopidogrel resistant metabolism related dysfunction, I think clopidogrel is one of the best thenoparities that we have. So it should be quite effective that way in combination with aspirin. The duration of therapy for ICAD, we have done a study where we have trying to extend the window from 3 months to a year. It has some problems, but we have not been able to come out with a final result as of today. Maybe that once the paper reaches some conclusion, we can decide beyond chance 2 of 3 months also
Yes,
for ICAD. That is
true.
one point that we need to say. And as far as I think that was the only question that was in the chat box, which was
Yes.
reflected.
The
Uh,
reopen trial also, maybe we can wait and see how what's the reopen trial says.
Yes,
Mm. Stenosis trial, not the reopen. Sorry, the stenosis trial.
stenosis. That's I was
Stenosis
mentioning
trial.
about stenosis only.
Stenosis only. Yes, I think we should, and also we should again design some more studies in Asian population. The duration of the therapy, whether it is 3 months or 6 months or 1 year, it all depends on, I think, our own population and risk factor profile. We should be doing this more often. We should take up more studies as you suggested.
That's right.
And these days we are doing cryptographic resistance in most of the patients. It is only 5,000 now. I think it can be affordable by many of these our
Yeah. And
patients.
clopidogrel, the cost can be brought down
Yeah.
much better. Once we can do
Yes.
a clopidogrel resistance, and if it is not there, we are sure that clopidogrel is as
Yes.
good as
Is working.
ticagrelor.
Is working. Yes. Right, sir. With less side effects of bleeding. Ticagrelor
Yes.
has a lot of definitely a high chance of bleeding either extracranial or intracranial. Especially extracranial, we have seen a lot of heavy bleeds in some of these
Yes.
patients.
Yes.
Ticagrelor is a very drug which have to be cautious. And hypertension
Especially
cannot
when
go up with
and
uncontrolled
especially
hypertension. It is not good. Yes,
and any stent, irrespective of whether it is in the heart or in the brain, there is no role for ticagrelor beyond 4 months
true.
because it gets fully epithelialized by that time. And because why I'm saying is, I had lost two patients who were on ticagrelor past 4 months due to
Uh,
intracerebral hemorrhage.
yes, sir. All these cardiac
That
patients
is
on
one.
this AXR, I think they are really they're put under unnecessary.
I have
Uh,
told my our colleagues here just try and stop it after 4 months, switch over to clopidogrel if you feel it's required.
true, true, true. Very true. So I think we had very good discussions and very good rare cases and rare problems and challenges. Both of them had through up. Each patient is a learning experience, as they say. I think if there are no more discussions and questions, can we close the session, sir, with your
Yes,
permission?
ma'am. Yes, ma'am.
Mm.
We can hand it over to the
Yeah,
organizers
yeah.
to.
Our academic part we will close and then we'll hand it
Yes,
over to Rajeshri once again.
yes, ma'am.
Mm. Hello, Rajeshri. Carry on. You can. You take care. Take.
Thank you so much, ma'am and sir. We are honored to have over 130 audiences join with us today, and they are listening to us. Definitely, this workshop has sparked many meaningful discussions I'm sure we'll have such kind of case discussions in future as well. So I won't take much time. Really honored and grateful to have you all here. You have taken your valuable time out of your busy practices. Thank you. Thank you, our course director, Dr. Vijaya ma'am, and our moderator, veteran Major General Dr. Kamara Velu sir, for your valuable insights and your leaderships throughout the session. And deeply thankful to our speakers, distinguished speakers, Dr. Reshma and Dr. Usha ma'am. Your expertise and contributions have enriched our understanding in many ways today. So let's continue to collaborate and innovate as we work together in improving stroke care and transforming healthcare together. Thank you all and very good night.
Thank you. Good night.
Thank you.